Welcome to this year's virtual 2020 CureOM meeting, and welcome to MD Anderson virtually. My name is Dan Gombos, and for those of you who don't know me, I am Professor and Chief of Ophthalmology here at MD Anderson Cancer Center. And a little bit about my background, a little bit about who I am. Come February, it will be 20 years that I've had the honor and pleasure of serving patients here at one of America's premier cancer institutes. And my career in ocular oncology goes back almost 20 years, almost 30 years. I first became interested in ocular oncology in 1993. And started to do research in the field. And that was as early as medical school, and have been involved with various aspects of eye cancer since then. I trained in cancer of the eye, not only in the United States, but also in the United Kingdom. And so I have a very collegial relationship with our colleagues abroad. I currently serve as the president of the American Association of Ophthalmic Oncology and Pathology, which is the subspecialty group of ophthalmologists, eye physicians who focus on eye cancer. And years ago, we were fortunate enough with my colleague, Dr. Sapna Patel, to host one of the earlier CureOM meetings here in Houston, Texas. And while our team is involved with many scientific, basic science, translational, and clinical meetings, the CureOM meeting is always a very different one. It's really one that is entirely focused on you, the patient, the caregiver, the family member, someone who has been touched and exposed to some aspect of eye cancer, and in this case, particularly ocular melanomas. What we wanted to do today is to give a primer on uveal melanoma. Most of the talks today will focus on uveal melanoma. I want to first focus on the fact that there are different types of ocular melanoma. Melanoma of the eye can involve the eyelid skin. It can involve the conjunctiva, and it can also involve the back socket of the eye. We call that the orbit. But when most people talk about ocular melanoma, what they're talking about is uveal or intraocular, inside the eye melanoma. And what we're going to do today is talk about it from a patient perspective. Now, some of this will be review for some of you. Some of this will be maybe some enlightening on your own personal experience. And I hope, again, with this virtual environment, that we're going to do things that we've never done before in the real environment, and that is bring in patients' experiences from around the world. And it truly is tragic that we have the pandemic and we can't be all together, and I can't touch you and see you and be with you and talk to you and help in any way we can. But we've turned this around and made an outstanding meeting, one that is now virtual but international. And our organizers have put together an international flavor that is inclusive of colleagues in Canada, Europe, Ireland, United Kingdom, Australia. It truly is amazing what they've done. And some of this certainly has a North American bias. I realize that, having spent part of my life in the United Kingdom, but many of these things are universal, and so I hope the talk will be helpful. And the good thing about virtual is if it's not helpful, then you can X out of it and no one will know, but you and me. I don't have any specific disclosures that are relevant to this meeting or this talk, but I am a former consultant to Castle Biosciences, and they do the prognostic test that I will be referring to. So you should be aware of that. And I have been an uncompensated consultant to Oral Biosciences, and I'll be talking about some of their clinical trials as well. So there are some amazing things about uveal or intraocular melanoma that are truly unique. The way it comes to medical attention, how we diagnose it, and how we prognosticate it. And the therapies we provide have been around for a while, but they're evolving. For many patients who've already had the diagnosis and the initial treatment of the eye, they're very focused on surveillance, screening for other tumors, and then treatment options for metastatic disease. And so we're going to go through all this in a step-by-step fashion. Key thing with all this is that uveal melanomas are not like skin melanoma. They both start in a melanocyte, a pigmented cell, but the mutations are different, the way they spread are different, and the way they come to clinical presentation are different. So let's chat about that. Let's chat about that a little bit. So one of the most amazing things about eye melanoma is that cancer specialists, eye cancer specialists, are very good, in fact, outstanding at diagnosing this cancer without ever taking tissue from the eye. And the most elegant way to show that is a huge trial that was done in North America called the Collaborative Ocular Melanoma Study, or COMS. We use it a lot because it was the only true first prospective, meaning done in a forward fashion, randomized clinical trial. And that's always the gold standard in medicine these days, prospective clinical trials. And in this study, over 1,500 eyes were removed with the presumptive diagnosis of melanoma, meaning there was no biopsy done to prove it was melanoma. The patients went to their doctor. The doctor said, you have a cancer. The eye was removed. And of over 1,500 eyes, only 5 did not have melanoma. That is an astounding diagnostic accuracy. And what that should tell you is that if you have a typical or classic melanoma, and we'll talk about what that is, you should feel comfortable and that the diagnosis has been correctly made, even without tissue, even without a biopsy. And that's sort of against the anathema of many components of cancer. One of the first things we teach people in cancer management is get a biopsy, get tissue, confirm the diagnosis. Well, for various reasons, we have not done that historically with the eye, and yet we still have very high diagnostic accuracy. And the reason that is because, we're able to put together symptoms and the appearance of the eye, and then certain diagnostic tests. And when they fit a pattern, that really comes together for an accurate diagnosis. And we're very fortunate in ophthalmology. We're sort of like similar in dermatology, is that we can actually see these tumors when they're small, when they're millimeters in size. And that gives us the ability to make the diagnosis with a sense of accuracy. We also have great non-invasive diagnostic tools like ultrasounds, and that support the diagnosis. Now, there are some scenarios where the front of the eye may look very atypical and give us a hint that there's a problem. But for many patients, the front of the eye looks normal. They don't have redness, they don't have swelling, they don't have anything that sort of says this eye is going to be a problem or potentially harbor a cancer that is life-threatening. Sometimes we will see patients with abnormal red blood vessels or a type of glaucoma. Sometimes we'll see a situation like this where we'll see pigment on the surface. This is not cancer, but this is a predisposition syndrome, sort of a birthmark area on the surface of the eye that predisposes to uveal melanoma. But in most cases, the front of the eye, or what we call the anterior segment, it's not that impressive. I think one of the challenges that patients always have early on is someone says they have a cancer and they're experiencing very minimal symptoms, usually just blurry vision. In fact, the most common scenario is a patient says, I was having some blurry vision or was having some flashing lights. I went to an eye care professional. They diagnosed me as having a retinal detachment. And when I went to have the retinal detachment looked at, suddenly I was told I had a cancer in the eye. And I think there is always this expectation that cancer has to be associated with pain. And in the majority of patients with uveal melanoma, when they start out, there is no pain. And in fact, there may not even be significant decline in vision. Depending on the size and location, the visual symptoms may be quite mild. Now, here's a picture of a melanoma. It turns out to be in the center of vision. So you would expect that those patients would have visual symptoms. But if they're off to the side, away from central vision, and they're small, it may be picked up on a routine screening exam. And that may be something that some of you yourselves have noticed. And that, I think, is the first shock. How can someone be telling me that I have a cancer when I don't really have any significant visual problems or symptoms or pain? And it's not as uncommon as you might think. Now, again, one of the things I'm showing you is that the ophthalmologist, the oncologist, is able to look at these things at a very small, I wouldn't say microscopic, but I'd say smaller situation than other cancers where patients are being seen by a physician who sees a much larger lesion, like a patient who has a lung cancer and there's a nodule in the chest, or a patient who has breast cancer and there's an abnormality in the mammogram. These are much smaller because of the way they're coming to medical attention. One of the things that is very common and we worry about a lot is when we see fluid. Now, for a patient, that fluid may be what they experience as distortion of vision. And here's a beautiful picture. If you look on your screen, you can see here the optic nerve. And then what I'm showing you here is this tumor. But if you look carefully, there is this outline here that's extending into the center of vision, and it's a pocket of fluid caused by the tumor. Now, technically, this is a form of retinal detachment. The retina is not where it is normally. And so that's why patients will be told you have a retinal detachment. But it's not like a retinal detachment that most people hear about and have to get treated. Most retinal detachments that people in the community are dealing with have a tear in the retina. And so the surgeon has to go in and fix the tear to fix the detachment. This is a detachment that's being caused by fluid, and the fluid is being developed from the tumor. The tumor is producing fluid, and that's elevating the retina off. And so the treatment is not surgery to fix the tear or the hole, because there is no tear or hole. The treatment is about treating the lesion that's causing the fluid. And fluid is something that I think most oncologists, when they see a lesion, they get very concerned about. Fluid is not something we generally like to see. And it makes us more concerned that the lesion is growing and is likely a cancer. One of the things people will notice when they're dealing with any ophthalmology visit, but particularly one in the back of the eye, we do a lot of tests. And people will say, well, why are you doing all these tests? These are ways to look for patterns that are consistent with cancer. Because again, we're not taking tissue, but we have great tests to help us figure out whether this looks like cancer or not. And here's all these tests that we sometimes do, but probably the single most important test, if you ask me and ask many ophthalmologists, is the ultrasound. Because the ultrasound will look for certain features that are often very correlative, associated with the cancer. So a lot of times you'll come in, first time in particular, and maybe go through an hour or two of testing before you even see the doctor. And that's very common. Now, this is what an ultrasound looks like. And there are different shapes that tumors can look like. But a lot of times you'll see that the oncologist will talk about the A scan. What is the A scan? Well, that's an ultrasound that's really just like a pencil. And it's shooting a beam of ultrasound from the front of your eye to the back of the eye. And if we angle it just right, we can angle it through the tumor. And depending on how the sound waves bounce, certain patterns seem to correlate very highly with melanoma. And what we're particularly looking for is what we call low internal reflectivity. You don't have to worry about the technical aspect, but just know that when we see that, it suggests strongly melanoma. Doesn't mean you can't have high internal reflectivity and not be a melanoma, but it guides us in a certain way. So you may notice that the diagnostician, the cancer specialist, is really spending a lot of time looking at the ultrasound, and that's why. But it's not the only thing we look at. We look at things like size, location, fluid. You'll hear all these terms. Orange pigment is one of them. What do all these things mean? Well, when we're not certain if something is a tumor or a birthmark, we'll use these different features to help us decide, is this more leaning towards something benign? Maybe we can watch it. Or is this leaning more toward something that's a cancer? And this is the art of medicine. The art of medicine is looking at all these risk factors and deciding if something is more likely to be cancer and therefore needs treatment, or something that could be watched. And so it's not uncommon for us to say, this is a suspicious area, but we're going to watch it. Well, why would someone watch something that's suspicious? Well, most of our treatments put patients at risk for visual loss. And obviously, we want to avoid things that pose risk to vision. But more importantly, we don't want to treat someone who doesn't need treatment. We also don't think that short intervals, months, likely pose risk or increased risk for a tumor spreading. And so it's not uncommon in my clinic and many other clinics to watch things that seem to be more benign. And many of those patients are watched for years and never need therapy at all. But again, this is the art of a oncologist. And so you may be a patient who is told early on, oh my God, it's cancer. But then you see the cancer specialist and they say, maybe not, let's watch this. And that may be a little bit disconcerting, but if anything, it should be comforting, because you have a clinician who is familiar with the situation and is comfortable saying, watch or don't treat. And again, watching doesn't mean we're not going to do anything. Watching just means we're monitoring things closely. And if you need treatment, we'll treat you. It's not common, but sometimes we have to do a biopsy because we're not sure, and that involves surgery, and that usually involves a specialist to look at the pathology. And a good eye specialist, eye pathologist will be able to help diagnose it, but sometimes even after biopsy, it's hard to know for certain. But fortunately, a diagnostic biopsy, a biopsy for the purpose of determining whether it's a melanoma or not, is not something that we often need to do. In fact, it's something we rarely need to do because we're so good in our non-invasive ways of making this diagnosis. Remember, go back to that study. Over 1,500 eyes that were removed, only 5 did not have the correct diagnosis. Now, of course, this is a disease that can spread, and so it's a bit non-intuitive. You think that a tumor in the eye is more likely to spread to the face or to the brain. But for reasons we don't fully understand, this tumor has a predisposition to spread to the liver and then the lungs. And so we'll often scan a patient from their chest down to their abdomen, and that's to show that there's no disease in that area. And the good news is that the vast majority of patients, when they first come to the eye doctor, they don't have disease in those areas. And so that allows us to get scans and then focus on treatment for the eye alone. In different centers, you may get a different scan depending on the health service you're in. It may be a CT scan, which is the preference at MD Anderson. It may be an MRI. It may be a PET scan. And you may say, well, why do different people do different tests? It's very complex. It has to do with resources. It has to do with what is the best test in your environment. It has to do with what, frankly, insurance allows. And it also varies a bit in countries. In the United Kingdom, liver ultrasounds are often used for screening. But unfortunately, because of the increased body habitus and body mass of many North Americans, that's not a good test for us here in the United States. And And so that's something that will likely have some significant regional differences. Staging is a big part of cancer management. And this is an area that's quite interesting and evolving. In cancer, we often talk about stage 1, 2, 3, and 4. And we do have a staging system for melanoma, and it's on your screen here. It does have a lot of scientific merit, but a lot of eye doctors don't use it because, frankly, it's quite complicated. And from a pragmatic perspective, if you don't have disease outside of the eye, then we're just focused primarily on treating the eye. And although it doesn't have as much relevance as it did years ago, a lot of times we still use an old classification system that was developed for the clinical trial I talked about, the Collaborative Ocular Melanoma Study, or COMS. And they sort of simplified tumors into small, medium, and large based on width and height of the tumor. It's not perfect, but I think most people can conceptualize sort of what is small, medium, and large. It's helpful. And so I like to use that because I think staging sometimes gets a bit overwhelming early on. And again, the majority of patients are not going to have distant spread when they come to the ophthalmologist. And so that's helpful. But there is a staging system, and it is prognostic. It does tell the patient that has a stage 1 disease or a patient that has a stage 3 disease. It distinguishes them. And a patient who has stage 3 disease has a worse prognosis than someone who has a stage 1 disease. But it's not universally used by all centers. And you may find that your team may or may not refer to it, but you're welcome to ask what your stage is, and it should and can be calculated for every patient. So what's the likelihood of spread? That's the question people always ask me, doctor, what's the likelihood that this is going to spread out of my body? And there are ways that we have been able to try to predict this in different ways. We certainly know that the part of the eye that's involved is a risk factor. And if you hear the word ciliary body, that's a part of the uveal tract, that has always had a higher risk of spread to other areas. Similarly, if your tumor is associated with the iris, and this is an iris tumor here that I'm showing, these tumors have a very low risk of spread. And in certain situations, almost no risk of spread. So location matters. We also know that size matters, and we've known this for many years. And there have even been some studies that shown that every increase in thickness and width are associated with a worse prognosis. Because of this, some doctors have been inclined to be more aggressive and treat smaller tumors than we used to in the past. But the corollary that treating a small tumor leads to better overall survival has really not been proven. So again, it's a little bit challenging, but we certainly have a sense that bigger tumors, wider tumors do have a higher risk of spread. We know that certain types of melanomas, there are different types of melanomas, do have a higher risk of spread. This was very helpful when we removed a lot of eyes, but increasingly we do one of two diagnostic tests. We call these prognostic biopsies. So we're not getting tissue for the purpose of telling you whether it's a melanoma or not. We're pretty sure it is a melanoma. What we're doing is we're taking a little bit of tissue and we're looking to see if you're a high, medium, or low risk category for spread to other areas. And that can either be done with DNA. This is clearly the preferred approach in many European centers. And they're often going to hear about this word monosomy, or one copy of chromosome 3. There are other chromosomes that they look at, but chromosome 3 is a critical one. Or what's commonly used in many centers is a commercial test called the gene expression profiling. And there are some reviews that suggest that if you combine gene expression profiling with another test called PRAME, P-R-A-M-E, and the width, that combination of data is very powerful to identify patients that are at very high risk of spread in the first 2 to 3 years after diagnosis. Now, how does the gene expression profile results come back? Well, your doctor will take a small amount of tissue, and send it to the laboratory, and it will come back as either class 1A, 1B, or 2. And then there'll be a separate listing for PRAME. You'll either be PRAME positive or PRAME negative. The best situation is a class 1A PRAME negative. It's always better to be PRAME negative than PRAME positive. And it's always better to be 1A versus 2. And think of 1B as sort of in the middle. We don't fully understand how PRAME fits into everything, but we certainly know that being PRAME positive is worse. Now, patients often have a long discussion, as they should, as to whether they should get a biopsy or not, whether they should be prognosticated. So let's go through that a little bit. Even if you don't have a biopsy, we have a good sense of whether you're likely to spread or not. How? Primarily based on size and staging. If you look at the staging criteria, it's very predictive of who's going to spread and when. So don't feel that in an absence of a biopsy, you can't be prognosticated. You can't know the likelihood of spread. But I can tell you, colleagues like my melanoma oncologist, Dr. Sapna Patel, really want to get that tissue. They want to get the prognostic test. And in fact, that prognostic test, whether it's DNA or the gene expression profile, they're some of the most accurate prognostic tests in cancer. And the reason they want that is because they want to know who's really at highest risk of spread. Those are the patients they want to watch, and those are the patients they want to offer clinical trials. But you should know that the standard of care, whether you're high risk or low risk, is still observation. So some patients really don't want a biopsy. Other patients really do want a biopsy. And I think it's really an important point to be carefully counseled. For those of you that weren't counseled about a biopsy, had your treatment and feel that you missed an opportunity, I would say we do have a lot of information from the size and staging that will still be very helpful to your team members and your surgeons. Biopsies, people often ask, well, are they risky? Are they going to spread the tumor? You know, there have been thousands of biopsies at this point, and we don't think that these biopsies pose a risk to spread. But they can be associated with some bleeding in the eye. They can rarely be associated with some complications. So I wouldn't say that they're risk-free, but the risk is felt to be fairly low. They do add a little bit potential for complications in surgery. Now, there are many types of treatments that are out there. The most common is either removal of the eye or some form of radiation. And depending on the center you're at, you may be offered plaque or protons or removal of the eye. It's very uncommon, but rarely we sometimes have to remove not just the eye, but the eye socket. And there are scenarios where sometimes we will offer laser treatment. Now, we don't often use laser treatment alone because we know that if you don't combine it with other things like radiation, the relapse or the likelihood the tumor come back is quite high. But as you'll hear at this meeting, there are some exciting new clinical multi-center trials with Aura Biosciences. They are trying to develop an injection of a virus-like particle that's combined with laser in an attempt to treat smaller tumors by preserving vision. And my colleague, Dr. Marr, who's on that clinical trial, will be presenting. So I encourage you to log on and learn more about that trial. So again, some of the treatment options, sometimes we can cut the tumor out, especially if it's a tumor of the iris, although not all centers will do that. Sometimes we'll remove the eye. And I have to say that while there's some centers that really don't remove eyes, I still think there's a role for that, particularly if you have a large tumor. And the reason is because there can be a lot of damage from radiation. And I think that really needs to be a strong discussion with you and your doctor. We can all try to save an eye with radiation. But if you have a really big tumor, sometimes even those eyes will have a very high likelihood of doing poorly with radiation and have a high likelihood of losing the eye and vision nonetheless. Some situations are where the eye already has a type of glaucoma called neovascular glaucoma. Those eyes really don't do well with additional radiation. So that's really requires a good talk between you and your doctor. This is the most common treatment that most centers use, and many of you would be surprised how it's done. But here's sort of a picture here where we have a non-radioactive plaque that we're about to put up near the optic nerve. You can see the little cutout here we've made for the nerve. And you can see in this pictorial how it sort of sits on the surface of the eye. And you can see that here. And it's amazing how well these things are tolerated. There are many different types of radioactive implants these days. Iodine is probably the most common in the United States. And in Europe, ruthenium is probably the most common. And our center is fortunate to have both. We're big advocates of using whatever is the best radiation plan for the patient. Sometimes we'll refer patients out to protons because we think protons is a better approach. And I think here as well, there is no one size fits all. You've got to talk to the doctor and ask them, you know, do you have modified iodine plaques? Do you have notched plaques? Do you have ruthenium plaques? Not all radiation therapy is the same. But where they are similar is that they all have excellent local controls. And in most cases, for a well-selected patient, the eye is likely to be retained, especially if the tumor is less than 8 millimeters in size. Now, once the eye is treated, we have to watch you because we know that there's a high risk of spread. And again, the staging or the prognostic testing will require that. And this will vary from center to center, how and how often they'll do that. And again, why is that? Again, different resources, different insurance policies, different approaches within the health system that you're in. It may be an ultrasound, it may be MRIs, it may be PET scans, it may be a CT, and that scanning and surveillance may be anywhere from a year to every 3 months, depending on your situation. And I urge you to counsel a medical oncologist who understands uveal melanoma, because this is very different than skin melanoma. And we're very fortunate here at Anderson to have a very collaborative relationship between a melanoma medical oncologist who specializes in uveal melanoma and the eye team and the radiation team who understand those differences. And it's really a small cohort of melanoma medical oncologists who specialize in uveal melanoma. And again, many of them, like Dr. Carvajal from Colombia, and many of the people on international colleagues specialize in this area. There's no standard of care for metastatic treatment. You know, we have pretty much gone away from systemic chemotherapy, and there are going to be many talks about treatments. But suffice it to say, we're in the era of immunotherapy and targeted therapy, and this is where we are today. And it's not, in my opinion, a slam dunk. It's not cures, but it is definitely an advance. And these are difficult words to sort of pronounce, ipilimumab and nivolumab, but this is where the field is moving forward. And I would remind those of you in the audience that for the first time in history, the Nobel Prize in Medicine went to a clinician here at Anderson, a scientist, who used the immune system to manipulate it and treat cancer. And it's the first development of immunotherapy for cancer management. And it's so profound that Dr. Allison here at MD Anderson won the Nobel Prize. So what's the conclusion for this sort of melanoma wrap-up? First of all, it's a rare disease, and it's different than other melanomas. And I think you've probably sorted that out at this point. But it is something that requires specialist care. It is something that lends itself toward a cancer center. individuals focused on this disease, both at the radiation level, the pathology level, the surgical level, and the systemic surveillance and treatment level. And many centers have that, and it's important to make sure that that's part of your care. Once the eye is cared for, we're obviously focused on the rest of you, and hopefully your doctors have been able to give you some stratification about the likelihood of spread. The standard, unfortunately, after treatment is simply observation, but there are exciting therapies out there and experimental treatments and clinical trials that are ongoing. And if that's something that you want to be involved with, I urge you to speak to your ocular oncologist or your melanoma oncologist about what's available. And if they don't know, there's a tight network of all of us who really work together. Dr. Harbour has led the Collaborative Ocular Oncology Group at University of Miami. Dr. Sato and Dr. Carvajal and Dr. Patel, melanoma oncologists, have really collaborated in an amazing way in North America to develop new therapies. There are other treatments that are available in certain centers like TIL or adoptive therapy, adoptive T-cell therapy. So there really is an enormous hope. We are learning more about this disease, but there's certainly more to be gleaned. And I really hope that this talk has been helpful. I hope that this meeting will be supportive and collaborative, and that through this virtual environment, you'll now meet more people from around the world and see that this is not something that's centered in North America, but really is a worldwide effort. We have enormous collaborative relationships. Before the pandemic, I mean, our oncology community would meet every other year in the International Society of Ocular Oncology and spend a whole day on nothing but uveal melanoma. And it really is an exciting field. Please, if you have any questions, happy to take them. Contact Dr. Sarah Selig or Lauren Johnson from RF, and I'm happy to address them. Please be safe, wash your hands all the time, wear a mask, do all the things so that we can all get past this horrible scourge and pandemic. And I'm sure we'll be meeting up again soon face to face. And I hope to welcome you all to Houston one day in the future, and take care.